And there's our graft. And then here is that same patient as we follow the patient out over time. This is the test graft on the top, the free gingival graft on the bottom, and at 4 weeks you are beginning to see the mucogingival junction start to materialize both here and here. The tissue is maturing. You're seeing keratinized tissue here around the teeth. And as we follow it out to 6 months, again, these final panels are stained with Schiller's iodine stain. A clearly differentiated mucogingival junction. The graft is withstanding muscle pull. Another patient, test graft on the top, free gingival graft on the bottom, and you can see the tissue maturing out to 6 months. And if we look at these panels, this is the close-up of what we're trying to achieve. Both very nice results as far as if our goal is to go in and generate a nice functional zone of keratinized tissue. You can see here, even though this is a nice free gingival graft, you see the borders of the graft, and that's fine, but that graft, even if you go in and plast it, it's going to come back and look like that. And the reason it will is because these cells always will retain their phenotype. They come from the palate, and they're always going to be palatal fibroblasts, where these cells come in from the native cells that belong there, and so you have the cells that nature wants to be there, and so we have a more natural appearance. Now, on our results in this study, we looked at width of keratinized tissue, probing depth, recession, clinical attachment level, inflammation, healing time, change in color and texture, resistance to muscle pull, and subject preference. And when we looked at 6 months to see what differences we had, these were the only parameters that there were any difference between test and control. And if we look at each one of the ones that had a difference, and we look first at keratinized tissue, the amount of keratinized tissue came out in favor of the free gingival graft, in favor of the control. We found that the amount of keratinized tissue generated with a free gingival graft was greater than the test graft, almost by double. But we found that the test graft was safe and capable of generating de novo keratinized tissue up to 4 millimeters without a donor site. And I think that's pretty outstanding if you can create up to 4 millimeters of keratinized tissue without taking any tissue from the palate. 24 out of 25 test sites demonstrated an increased amount of keratinized tissue, and 3/4 of the sites yielded 2 millimeters or wider. If we look at the parameters change in color and texture, these came out in favor of the test site. Not surprising, because remember, this material is stimulating de novo regeneration of the patient's tissue. It's not functioning as a tissue replacement graft. It's stimulating the cells to come in that really belong there. So of course it's going to look more natural. You're not going to have this patch-like look. You're going to have a more natural look of tissue that really belongs there. And then the final parameter that was different is subject preference. And you can guess which ones you think you might rather have. Do you want to have somebody carve on your palate, or would you like to have somebody open a bioreactor and take the tissue out of that? Now, the positive outcome of that particular pilot study then led to a properly powered multi-center study. We know that it's possible through the pilot study. Now we want to refine it more through a multi-center trial. And this is one that we have finished all the surgeries on. It's, again, basically the same study design as I just showed you. The pilot in which we're going to see if we can create keratinized tissue. We're not trying to do root coverage. And the different centers that were involved was our office in Houston, Mark Nevins in Boston, Drs. Cochran and Melling in San Antonio, and Will Giannobili and his group in Michigan. All of the study, all the surgeries are complete, and we'll finish data collection on these folks about Christmas, this coming Christmas. So sometime early or late winter, we should be able to begin looking at the data and really see what we're getting here. Now, it's a much larger study, a 96-patient study, 4 centers. A primary efficacy parameter here, we're looking to create keratinized tissue greater than or equal to 2 millimeters. We're looking at a number of other things, the typical things you would look at in any study: color, texture, patient preference, sensitivity, pain, and all of the normal characters you'd look at in any sort of a periodontal study. We did a few things different in this study, based on lessons learned. As you see, we've got a much bigger piece of tissue here than what we were showing you before. The Video's having a hard time here. Again, I'm telling you, quit thinking of this as a tissue replacement graft, yet even we're thinking of this as a tissue replacement graft, in the Palate study. We're having a difficulty getting away from this, and so there's no reason to standardize the width. So we're placing a much wider zone of tissue here, and also we're going to put a little protective, another layer of this material as kind of a protective covering over the graft itself. And so we've changed our techniques a little bit here, and to see if we can actually improve the outcome. Let's see if I can get out of this video because it's not acting very good.
Is this the same material?
Same material, yeah. We're just, we learned some lessons in the pilot that we're changed on our multi-center trial. So here is one of our patients at our site. You can see no keratinized tissue here at day 0. This is the test graft, the free gingival graft at 6 months. We have a nice functional zone of keratinized tissue, very equivalent to what you see with the free gingival graft. Another patient this is the test graft here, free gingival graft here, and a nice zone of keratinized tissue here, similar to what we have with the free gingival graft. Another one, test graft here, free gingival graft here, and again, you look here, just all mucosa, and you can really appreciate the nice zone of keratinized tissue we are creating here without a donor site at all. And the final case, again, if you look here, just all mucosa, and here we have a nice zone of keratinized tissue, and this is the connective, the free gingival graft. If we look a little more up close, you can see, the blood vessels and everything, the mucosa, just all mucosa, and a very normal-looking zone of keratinized tissue, and we don't have that patch look that we have on the same, the same patient on the opposite side where we used our keratinized tissue. So hopefully we will have some data to report to you early spring, and hopefully this particular study will lead to FDA approval of the material. We also have just begun another pilot study using this material. We're wanting to see, okay, now we have proven we can generate keratinized tissue with it. Can we use this for other things like root coverage? So we're looking at that with comparing it to connective tissue. This is a pilot study, 26 patients, 6-month study. And our treatment is either a Miller class 1 or 2 recession greater than 3 millimeters, and we're either going to have coronally advanced flap with the test material or with connective tissue graft. Looking at primary study objectives, basically just safety and trying to collect information that will allow us to move into a properly powered pivotal study in the future. Looking at a lot of different composite measurements, I think that you'll find in the future more and more of our studies based on aesthetics are going to be using composite endpoints, and I'll get into that in a moment as we move into another study, why I think that this is going to be more important. This is one of the cases of where a fairly deep, wide area of recession. We're placing the material in this, we're using just 2 layers of the material rather than 3 for the root coverage. And here I've sutured it down, coronally advanced the flap, and I'm going to leave you as a cliffhanger here. You'll just have to tune in as we go next year to find out what our results are. Now, as we move on with our live cell end of the tissue engineering spectrum, one of the areas that you and I have not been able to manage is to regenerate papillas using traditional periodontal plastic surgery. So we published a paper in 2007 using autologous cells in an attempt to do this. We go in, we harvest a little piece of tissue from the palate, we send the tissue to a laboratory, they go in, they separate the cells, create a cell line of the patient's own autologous fibroblasts. These cells are expanded out to a concentration of about 200 million cells per ml, placed in an injectable medium, and we're going in and we're injecting this into the papilla with the idea that we're going to expand the papilla. Now, it's not this is not a filler, so it's not like we're injecting collagen or something like this. We're injecting living cells. And because these are living cells, theoretically they have the potential not only to maintain the result, but to perhaps improve it even over time. Now, we're learning a lot about gingival fibroblasts as we do all of these studies. I used to think of them as mundane cells, sit around and produce collagen, and that's about all they do. But as we talked about a moment ago in the other studies, these fibroblasts are producing all sorts of cytokines. They're important for cell proliferation, extracellular matrix production, cytokine production, And it's very interesting that gingival fibroblasts have a great deal of phenotypic heterogeneity. That if you can stimulate these fibroblasts into the direction you want them to go, you can actually create bone with this, all sorts of different cells with fibroblasts. You can get more undifferentiated mesenchymal cells from gingival tissue than you can any other tissue in the body. And so again, theoretically, you could actually create regeneration with fibroblasts. So here we have the magic potion, but what makes me think we're going to be able to inject this in a papilla? Most of you in the audience have injected local anesthetic in papilla. You know you can't inject any sort of volume of that into the papilla. Why would we think we can do that? Well, of course, we can't. Now, this material was originally tested for facial wrinkles, to plump that out. Now, obviously, you could expand, the tissue on the face. So this was something that we knew we'd have to resolve, so we created what we call the papilla priming procedure. It's just a controlled surgical insult where we go in and do a minor little surgical incision into the papilla, basically to do two things: to cause the papilla to swell and to kick off the body's own healing cascade, because we're going to try to leverage what the body does itself as it heals a wound. So here is the little papilla priming procedure. You can see the tissue swollen at 3 days. It's remaining swollen at 7 days, and by 21 days it's completely back down. Well, how can we leverage this to our, for what we want to achieve here? So here is, we're injecting the cells here. If you watch the tissue, you'll see it blanch. We're either injecting 20 million cells per ml or placebo here in our study. What we found was we could get about 6 to 8 million cells into one papilla. And if you'll note on my timeline, we did our first injection at about 5 to 7 days after papilla priming. We chose that on purpose because if you remember back to wound healing, at about 5 to 7 days, you're moving from the inflammatory phase of wound healing into you're just beginning the granulation tissue formation phase. And at about 5 days, the body is beginning to shut down its own natural production of fibroblasts. Okay? You've cut yourself or something, the body has to heal itself, it begins to produce fibroblasts. The fibroblasts are producing collagen, and at about 5 to 7 days, the body says, okay, that's enough, no more fibroblasts, collagen production begins to wane. So we're coming in at the tail end of where the body starts shutting down its own fibroblasts, and we're going to infuse our own fibroblasts in an effort to continue on this granulation tissue formation phase, and we do it in a dosing schedule. Again, something we're not used to doing in periodontics, but it's done in medicine frequently. And we're going to dose this every 7 days for 3 different injections in an effort, again, to get as many of these living fibroblasts into the tissue. The idea is these fibroblasts then take up the normal residence in the dermal tissue. They're producing collagen, stimulating the native cells to produce collagen, and it thickens the dermis. So you're getting a thicker tissue here. We measured our changes in lots of ways, but the best and most effective ways we found to watch these changes was through fairly sophisticated analysis of digital photographs. And so this panel is the day 0, this is at 4 months, and just all the different intervals. But if I put it into a graph, I think it's a little easier to see. Now this first time point, and by the way, on the y-axis is the distance, and so up here is a open interproximal space, and down here is closed interproximal space as you get to the x-axis. So this is papilla priming, and you can see after we do our little surgical insult, we haven't done anything but the little surgery, and you see it swell. So you're starting to close the interproximal space just from the swelling. So this is first injection, second injection, third injection. So that's 1 week, 2 weeks, 3 weeks. Look what happens after the third injection. Even though we've not injected any more, look at how the interproximal space closes. Now, why would that be? Well, it's because, again, these cells are sitting there producing fibra, they're producing collagen and all of that. It's thickening the dermis, it's closing down the space, even though we haven't injected any more cells, and then stabilizes, and now we're out at 4 months. You can do anything with a computer, but this is not a computer-altered thing. This is simply just a time lapse. I want you to center on this middle screen. Watch what happens to this open interproximal space from day 0 to 4 months. So through this pilot study, we know that it is possible. We have done another little study to look at different dosing regimes to further refine our measurement techniques, because that's critical in this type of study. And we hope that with proper funding that we can move this into multi-center trials so that we can take what is possible and really refine it and make it more predictable. And if that happens, then I'll be setting up Papilla parlors next to every bright smile thing all across the country. Let's move then from the live cell end of the tissue engineering matrix to the biologic mediators. Now, the first one I want to talk about is enamel matrix derivative. And when you begin to read and think about biosurgery, you'll start bumping into both of these terms, tissue engineering and biomimetics. And they're similar, but there are some useful differences between the two definitions. Tissue engineering builds on the interface between material science and biocompatibility, integrated cells, natural synthetic scaffolds, and specific signals to create new tissues. Biomimetics, on the other hand, is the science of reconstructing or mimicking natural processes or tissues with the expectation that regeneration will follow. And the best example that I know of biomimetics is what happens when we place enamel matrix derivative on the root surface. We do that in an effort to mimic the natural process of tooth development with the expectation that regeneration will follow. Now, if you go back to kind of illustrations on mechanism of action of enamel matrix derivative, and we're still learning lots about this material. I mean, it's kind of an amazing material that we continue to discover really what it's doing. But in kind of a basic way, the way we think this works is that it causes undifferentiated mesenchymal cells to migrate into the defect. They attach to the root surface. They proliferate once they get into the site. And then they differentiate into all sorts of things. And the collagen, they're producing interleukin 1 and 6 and TGF-beta 1, which is stimulating matrix production. It's preventing epithelial downgrowth into the defect. All sorts of things are happening. The collagen begins to accumulate kind of at a fixed distance from the root surface, and then it goes through mineralization, and finally you get an attachment apparatus. Now, when we began working with this and doing our study on this, all of the work up to this point had been on intrabony defects. But because of our interest with soft tissue, I wanted to see what could we do to leverage this with root coverage for root surface defects. And so again, we want to compare that to at least what is in the United States the gold standard for root coverage, and that's connective tissue. And this is a two-part paper that I'll just touch on because you can go back and read it in the journal in great detail if you're interested. It was an interesting study in that we went a full 12 months rather than 6 months. We looked at all of these different parameters. There was no difference between these parameters at baseline. And when we looked at it a year, only these variables were different. Now, the study wasn't powered for equivalence, but what that means is these are the only ones that there was any statistical significant difference, which means all the rest were basically the same, whether we're using the coronally advanced flap with the enamel matrix derivative or we're using the connective tissue graft. But let's look at some of the ones that were significant. Now, if we look and see the type of defects we were treating and the surgery involved, we're looking, this study, we had big defects. And so broad, deep defects. This will be our control defect on this patient. You can see a fair amount of root surface abrasion here. This is a partial thickness flap. I'm just making some intraoperative measurements. I placed connective tissue in here, coronally advanced the flap, and at 1 year, very nice root coverage. This is the little coronally advanced flap that we place over it, and this, kind of pulling down over time. If the patient wasn't in the study, I'd come back and plastic that off to make it look even nicer. But, I'll take that any day. That's a nice result. 100% root coverage, good result. Okay, same patient, opposite side. This will be our test. Mirror image lesion. And like the one I just showed you, a lot of root surface abrasion here, 2 millimeters. Now, with the connective tissue I just showed you, that's kind of like putting an inlay in an inlay prep. But how about this? 2 millimeter root surface abrasion, and I'm going to put a viscous enamel matrix derivative there. What's going to happen with the tissue when I place it in? Is it going to collapse onto the root surface? Is that going to be a problem? Well, here we have it a year. you can see 100% root coverage, very nice aesthetic result. And if we look at the emergence profile on the tooth, you can see how the tissue is maintaining proper emergence profile. No, it didn't fall into the defect. And so a very nice result. And we got that with all of the patients that we treated in the defect in the study. So that was, it was something I was concerned about as we moved in, but it ended up not being a concern. We looked at probing depth in the study using Florida probe. And I put this slide in only because I think as a group, periodontists, we need to do a better job when we're talking to our general dental colleagues. As I talk to people all over the place, so many people think when we place grafts, we're creating pockets. We know we're not creating pockets, but we need to better communicate that to our to our colleagues. And so here with some industrial strength probing with the Florida probe, you can see that at all time points up to 12 months, we had less than 2 millimeter probing depth with all of our patients, and we had less probing depth with our enamel matrix derivative than we did with our connective tissue graft, but it was all less than 2 millimeters anyway. Now, if we look at with the keratinized tissue, that was another interesting thing, that we had, all the patients had at least 2 millimeters of keratinized tissue before they entered the study. At all time points, the connective tissue graft yielded more keratinized tissue than did the enamel matrix derivative. That wasn't surprising to me because most of us feel that the connective tissue from the palate is genetically encoded to produce a keratinized surface, so I would expect more keratinized tissue. But what I didn't expect is look at the trend here. From 6 months, 9 months, 12 months, we continue to get increasing amounts of keratinized tissue. So it kind of begs the question, what if we'd extended the study, to 2 years rather than 1 year? Would these merge at some point? But as I begin to think about that, I say, maybe we don't really want that. What's enough? And again, we want to try to end up and have what Mother Nature intends there, not this big kind of scar of connective tissue. So here is the control side. Again, very little keratinized tissue here. We make our partial thickness flap. I place the connective tissue here, coronally advance the flap, and here we have it a year. A very nice result as far as root coverage, a great big zone of keratinized tissue. And of course, that's going to be, that's probably going to be more keratinized tissue than we're going to get with the coronally advanced flap and the enamel matrix derivative. But my point is, do we really need that? Same patient, opposite side. Very little keratinized tissue here. We make our partial thickness flap, place our enamel matrix derivative, and coronally advance the flap. And here we have at a year. Clearly you can see an increased zone of keratinized tissue here than what we had here, and that was a trend that we saw throughout the study on all of our patients. Now, if we look at root coverage, we had both tested control groups demonstrate an average of 4.5 millimeters of attachment gain over 12 months. We achieved with our control, our connective tissue graft, about 94% root coverage, and with our coronally advanced flap with enamel matrix derivative, 95% root coverage. Now, it's important when we look at percentages to have benchmarks so we know what we're comparing to. And if you look at the systematic reviews, the meta-analysis, most say that in a Miller class 1 and 2 recession, you're going to expect about 89% root coverage with a connective tissue graft. So we're bettering that with our 94%. How about, well, what's the difference if what would just a coronally advanced flap with nothing under it? What would you expect there? And the meta-analysis say you'd expect about 82% root coverage with that. So we're clearly improving over what the systematic reviews would say on amount root coverage. Now, another thing that we look at for effectiveness is how often can we expect